This is Dr. Roy Davidovich from the NYU Langone Orthopedic Hospital presenting the RotexTable attachment for anterior approach total hip replacement. The RotexTable attachment is a partially automated, completely surgeon-operated table attachment for anterior approach total hip replacement. The Rotex attaches to a regular operating room table. It is radiolucent and allows intraoperative fluoroscopy. It also stores with a footprint similar to an IV pole when not in use, which is ideal for operating rooms tight on space or outpatient surgical centers. The surgeon has complete control of leg positioning and does not rely on an unscrubbed or specially trained assistant to manipulate the table intraoperatively. Therefore, only 2 surgeons are absolutely necessary to execute the procedure. We present here an abbreviated anterior approach total hip replacement case performed with the aid of the RotexTable attachment. We will be focusing on the distinguishing characteristics of this device. The RotexTable is brought into the room in a collapsed position. It easily stores in this position as it assumes a footprint similar to an IV pole. The patient is brought into the room and undergoes anesthesia. Once this is completed, the patient is turned into a supine position and is brought distally around the available radiolucent post. The operative leg is then padded and fastened into the lightweight carbon fiber traction boot available with the table. The leg board is removed, and the Rotex attachment is simply fastened into position with a single click. The boot is attached to the Rotex device. The surgeon controls rotation of the extremity through the drapes via this ratcheted lever. When the lever is turned anteriorly, the leg can be locked into an internally rotated position. In neutral, the leg is left into neutral rotation. Posteriorly, the leg can be locked into an externally rotated position. The externally rotated position is ideal for femoral prep. For the majority of the case, the leg is placed in a neutral position, allowing free rotation of the extremity. A pedal allows the surgeon to control extension and flexion of the hip via this automated mechanism. The base of the Rotex is left unlocked and moves passively during hip extension and flexion. This prevents any undue tension on the extremity. Gross traction can also be locked through the drapes via this switch. As a safeguard against extension of the hip under traction, which can cause a neurovascular injury, extension of the hip is disabled under gross traction. The surgical field is then draped in this fashion, allowing for access to the rotation lever as well as the traction switch through the drapes. Acetabular prep is straightforward and undertaken in routine fashion under fluoroscopy. Note how the assistant surgeon holds the leg in a slight figure 4 position for femoral head removal. For femoral prep, the extremity is ratcheted into external rotation. The surgeon can simultaneously externally rotate the extremity and assess for proper tension. The surgeon utilizes the pedal to automate the hip into the desired degree of extension. Adduction is easily achieved as well. Following femoral prep, the hip is brought out of extension, the ratchet mechanism is placed in neutral, and gentle traction and internal rotation is utilized to reduce the hip. The extremity is placed in extension and external rotation to check for anterior stability. It is then brought back to neutral to check for posterior stability. The boot is detached from the ratchet mechanism through the drape to achieve this. At the conclusion of the procedure, the drapes are removed, the boot is detached from the Rotex device, and the Rotex attachment is uncoupled from the table. The leg board is attached, and the boot and post are now removed. The patient is ready for transfer to the post-op recovery unit.